Assalamu alaikum. Good evening. So today we will read the only small part of the respiratory system that actually could not complete it the last session. So that was related to the stridor. Actually, stridor is very important. So that we will now details discussion over this. Let us start. So before that, do you have anything query, any questions related to the remaining part of the respiratory system that we covered so far? If it is not there, then we can start. Dr. Sadia joined. Okay. So today's topics is croup, or you can say that one of the respiratory sound we should know. Okay, so this respiratory sound is stridor. So already we discussed one of the respiratory sound that is related to wheeze. So we call it wheezy child, and wheeze is related to not only asthma. We comes to know that there are different causes which can be related to the wheeze, right? So now another respiratory sound we can heard that is stridor. Okay, so this is primarily called inspiratory respiratory sound. Inspiratory, right? But you should know that it is primarily inspiratory, but not always inspiratory. It can be expiratory as well, and it can be a biphasic. No, can be biphasic. So could be inspiratory, expiratory, both. So this respiratory sound, that is stridor, is related to the upper airway obstruction mainly. Okay, so it is not related to the lower airway. That is, for example, it's not pneumonia, it's not a lungs related problem. Okay, so it is upper airway obstruction related. So what could be the causes behind for this stridor? Anything related you can you know about anything stridor related sound, other respiratory sound? Stridor. It's mentioned in the Science of Pediatrics books. It means intermittent obstruction. Then the sound is called stridor. It's not our task. Now we will do the stridor. So what could be causes behind the stridor? So anything causes, whenever we try to find out what could be the causes, remember infection is one of the cause, trauma could be a cause, tumor could be a cause. Okay, so trauma, tumor, vasculitis, this is a general. Whenever we have to find out any cause, then we can divide it by this way: infection, trauma, tumor, vasculitis, hemorrhage, and many things. So we can see that how stridor or upper airway obstruction is related. So first of all, that stridor is infection. So what could be the infection? Any idea? Viral cause. Viral infection. What's your idea? You can write or you can open your mouth. It's one of the important infection that is virus related is acute laryngotracheobronchitis. Okay, acute laryngotracheobronchitis, which is known as croup, only croup. Whenever we say this is a causes of stridor, viral cause. Don't forget that acute laryngotracheobronchitis or croup. So I said that there is other causes, there is epiglottitis. So virus. There is bacterial cause, that is tracheitis, only tracheitis. So these are the things is related to the infection. There are a lot of causes behind, but we are now taking the most important things, and yeah. So most important things which can be asked in the exam or which can be required in our day-to-day life whenever we are dealing with the patient. Yeah. So people are joining. We are talking, those who are joined lately. So we are talking about the stride or upper airway obstruction, which is very important. And there are different causes. One of the causes infection. And we say that there is one of the viral causes is acute laryngotracheobronchitis, which is also known as croup. Okay, and there is another cause that is called bacterial tracheitis, which is a bacterial cause, and we say that there is a epiglottitis. So other than this, if there is a severe any trauma, so that can be also important cause to the upper ear obstruction, then you can get, but it's never ever came in the exam like this way. Okay. And any other cause? Very important. It's not related to the trauma, but for child, it's very important. Foreign body. Never forget, if it is obstruct upper airway, then also foreign body can cause upper airway obstruction. And also another important things is anaphylaxis that we have to remember actually. Okay? So you can say allergic. It's one of the allergic phase. Okay? That is the anaphylaxis. Or smoke inhalation. It also can cause, but usually it is not. I mean, we do not have to find out these things, because it is from history. They will give you in the questions that there is some fumes, and you can easily pick it up. As well as important things is like whenever we think obstruction is important cause, and there is trauma, foreign body, and there is another things which obstructed, that is the lymph node swelling. Lymph node if swollen in the upper airway and they obstruct, then also you can get the like stridor. Okay, so it could be like tuberculosis. Lymph node is swollen and its laryngeal area is swollen, and then could be like a stridor. Okay, as well as you can get another important thing I want to here say that that can lead to the stridor is diphtheria, although it is a bacterial cause. Okay, bacterial cause. And please, we should not forget for the stridor, then it is hypocalcemia. Okay, hypocalcemia can cause stridor, right? Also, I can remember about retropharyngeal abscess. So they will not never ever ask you what could be the causes of stridor, but these are the causes that can help you whenever there is one questions and they give you a scenario, so you have to pick it up the right answer. So this information can help you. But actually required is the most common cause of stridor is that I said. It's also known as acute viral tracheobronchitis, acute viral tracheobronchitis. Another name, acute viral tracheobronchitis. So what happened? Due to viral cause, child having upper airway could be obstructed. It can cause edema of the larynx and trachea, and they can present it to you cough. Okay, and this cough is, I want to here explain you how the croup or acute laryngotracheobronchitis presented to you. So it is, there could be like upper respiratory infection, first of all. So cough, nasal distress, it could be like this. But here, specialty, because it's a viral infection, what I said already. So specialty is the cough, and it is called barking cough. It's the name. Any scenario, they say barking cough. Think over acute laryngotracheobronchitis. It's called barking cough, and also it is said like seal type of cough. Okay. And this child can have temperature low grade, but it's not high grade usually. Okay. And they could have other features of respiratory distress, but the cough is here important. So cough with respiratory distress and upper respiratory infection features along with stridor. So we will remember this cough and stridor mainly with or without respiratory distress. So already I said you that this is some agents viral. So which is this? Parainfluenza virus, that this is the question for TAS exam question. Parainfluenza virus, sometimes it is influenza virus, sometimes respiratory syncytial virus, rhinovirus. So we will remember parainfluenza virus, and then PI, influenza virus, PIR, respiratory syncytial virus. So whenever we say bronchiolitis, which causes bronchiolitis? Respiratory syncytial virus, right? They are parainfluenza virus. There is some difference. It's commonly happen in the winter period, and it's happening 6 months to 6 year, peak age 2 year. Transmission usually by droplet spread. Okay. So it is. These are the questions. All these are the task questions. Remember. Now, so always whenever you read, you have to correlate with the bronchiolitis, which is the peak age they are and which time it's happened by this way. Okay, so another things is bacterial tracheitis and epiglottitis. Epiglottitis is very, very important. Once upon a time, it's a killing disease, but bacterial tracheitis, if I want to say about, first of all, epiglottitis, it's happened having same stridor, respiratory distress, but it's caused by Haemophilus influenza. So Haemophilus influenza is a bacterial cause, the bacteria. But problem is this Haemophilus influenza cause, what I say, killing disease, but this Haemophilus influenza is now prevented by the universal vaccination program. So now it is very rare. But what is their presentation for epiglottitis that we have to remember? Acute epiglottitis, they have drooling saliva. They will be sick, very sick, toxic. Any kinds of bacterial infection means they will be toxic, right? So the bacteria, and there is no features, it's very rare. Okay. So drooling, very sick, toxic, irritable, cannot eat, drink, and they can be rapidly deteriorated. So I said bacterial tracheitis and other things. Bacterial tracheitis, the clinical manifestation is same as like acute tracheobronchitis or croup, only croup, which I said you. So this bacterial tracheitis, child will be same with, child will be toxic. So any child, if you think it could be croup, acute laryngotracheobronchitis, but the child is toxic and high grade temperature, think over bacterial tracheitis. Are the three differentials which we have to know. Okay, so if you just think this, if you have confusion, you can go through this difference, then you can understand, and you have to know this well. Okay, the difference between this viral croup and bacterial tracheitis, along with epiglottitis. and their agent. So what is caused by the bacterial tracheitis? Which agent is there? Is that the Staphylococcus aureus? Okay. Yeah. So whenever there is a croup or a stridor, actually here this it is taken from the pediatric guideline, but pediatric guideline stridor part is very important, or said it's now discussed as a croup. So croup can be, I mean, here they give you croup severity or croup, mild, moderate, but you will, you have to differentiate, you have to know that it is the actually stridor, classification criteria, okay? So mild croup, moderate croup, and severe croup. Mild croup means they will be only barking cough, other than everything is mild. So no recession, no cyanosis, mild stridor. So this mild stridor means this stridor is not persistent throughout the day, or not, with the activities not varying, but there is sometimes some sound is coming out. So this is called mild croup. Barking cough is very important. Barking cough, still type of cough. Okay, remember this word. So this is called mild croup. And moderate croup means, so you see that whenever we are differentiate, we try to understand that how their stridor or croup condition. Stridor, how their cyanosis is there, how their vitals, and there's recession of respiratory. As a pediatrician, pediatric trainee, we all know that very important things is how the chest is moving. Recession is very important part, right? So it can help you to differentiate. Then you go to the moderate group. Here you see this mild stridor become intermediate stridor at rest. So this stridor is not with activities, it is only at the rest. Mild recession, alert, responsive. So the mild moderate difference is only at rest type stridor. Okay. Then go for the severe group. Severe group is, severe group is indicated that child will have stridor at rest, that is related to the moderate group, but here vitals is unstable. Cyanosis, saturation low, apathetic, restless, moderate to severe chest recession. So as a whole, if I say that what is the difference between mild, moderate, and severe group, you will say most important mild group is sometimes there is stridor, but there is cough, barking cough. Moderate group, you will say stridor at rest. And severe group means all the features of severe respiratory distress is there. That is the severe group. So why we are differentiate between mild, moderate, and group? Because we have to know that how we manage. It depends on which kinds of group they are. Okay. So even in the pediatric guideline, they say that C for cyanosis, recession, saturation, upper airway obstruction, sound, respiratory rate, heart rate, they can help you to differentiate that how much severe they are. Okay. So this is the actually the difference clinically, and how we assess the child with the stroke. And this is a kinds of stridor, which is acquired. It's not a congenital kinds of congenital kind of stridor. Okay. So all the things now we are discussing is acquired kinds of stridor, among them viral, and we are focusing on the acute laryngotracheobronchitis. Okay. And the difference we have to know and how we will manage this child. So remember, any child with a stridor, I don't know how much how much important things you understand or not, and how can I emphasize this, that stridor child you cannot examine throat. very important, red flag sign. And these questions, this is one of the questions which came repeatedly in the exam because it's very important. And you can't examine a child of stridor. If you do it, then you can deteriorate the child. So it's very important, don't go for examine the child's thought. So what you can do during the examination, you are checking the child's sinus, tail, and you can just look at the child and you can count the respiratory rate, and you can just give your stethoscope on the child's chest, and you can see the heart rate, as well as you can that time heard their respiratory status, but you can't say open your mouth. Okay, that is very, very important. So they can ask you which investigation you want to do for the stridor. You will say, no so no examination, throat examination, no investigation. So as like examination, investigation is same, no investigation is necessary until you think it is a croup bronchitis. So no investigation is necessary. From our MBBS life, we comes to know that chest X-ray can be then X-ray, nasopharynx, lateral view, many things. But no, for the croup, acute croup, even acute epiglottitis, you have to first stabilize the child, right? Stabilize the child. Then you go for the other things. So if require investigations, even if it is bacterial tracheitis, so you will give bacterial infection, right? So you will give the CBC, CRP, many things. But first you will stabilize the child, then you can give it. Okay. So any child management critical situation, airway breathing circulation will stabilize. So how you will do this? If it is mild moderate, so we can give fluid, appropriate fluid intake advice, and paracetamol or ibuprofen, that is to keep the child calm and quiet. And you can give leaflet to the mom. So leaflet means something, in the patient language, every hospital having a leaflet on the common disease where it is explained by the parental language, or you can say those who could not understand our language, our specific what we use medical term. So with non-medical term, they explain it, and leaflet is available in each and every hospital's their website. So which is known as leaflet, and you have to give it to understand and to give the child parents reassurance is very important. So you are not going to do anything. You are not advise hospitalization even. For going not to hospital, just you have to observe the child if required up to 4 hours. In between time, you can give paracetamol, you can give fluid, and to take the fluid intake orally actually, and it will be the advice for the parents. But one medication you can give, and you have to remember by heart, that is oral dexamethasone. So remember, they sometimes say steroid. I mean, the option is steroid because dexamethasone is one kind of steroid. So you can take dexamethasone or steroid. Its dose you should know 50 microgram per kg orally. Okay, but if the child is, sometimes child happen, they don't want to take any kinds of oral medication or something. Child is especially early age child, it's very difficult to give their medication. In that time, you can give nebulized budesonide milligram. So it is mentioned, and you will observe them up to 4 hours and reassess, and then you can discharge the child from observation, but they can take another dose of dexamethasone after 12 hours. So they said in the guideline that do not upset the child, do not upset the child. So even if you need to give the oxygen, you have to give the ask to the mom to give the oxygen. So mom is most reliable for them, and they will arrange it by this way. But if it is severe croup, those having they have croup, and they have features of like severe respiratory distress, sinus respiratory rate is too much, and severe respiratory recession is there. In that time's admission, And then you have to give high flow oxygen 15 liter per minute. It's not said that we here oxygen level, they say 15 liter per minute. Okay, with reservoir bag, and you have to give nebulized adrenaline. It's called nebulized adrenaline, not budesonide. Here, nebulized adrenaline 400 microgram per kg. So dose is not required here. Then you can repeat and you have to observe it. But they say that have to observe 3 hours, more than 3 hours in between time. You have to contact with the consultant pediatrician and pediatric anesthetist, ENT surgeon, especially if it's not controlled by the adrenaline, then ENT surgeon, pediatric anesthetist should come, and maybe child require ventilation. Okay, so that is very important. But usually if it is epiglottitis, they require immediate intubation, because very in critical situation, epiglottitis, which is caused by Haemophilus influenza, and they require immediate intubation, and then require IV antibiotics, ceftriaxone. It's not mentioned in the pediatric guideline. Okay, their epiglottitis child will be like, they will be forward. They sit by tripod position. They will take their even legs in front, and they will sitting forward to overcome the respiratory difficulty. So their management is like this. And for bacterial tracheitis, usually their situation is not good and require intubation, and here antibiotics is injection flucloxacillin, because Staph aureus is the causative agent here. Okay, so these are the things for management. Any questions so far? So, and humidified air cannot help. Antibiotics cannot help if it is acute bacterial tracheitis caused by the parainfluenza virus. And also if it is drooling, labored breathing, persistent fever, they have to be come back whenever you discharge the child parents, and then when they will be come back, it is that is the call, the red flag sign. If not, then parents will be come back. So you discharge the child of acute bacterial tracheitis. In that case, if it is like cyanosis, consciousness and drooling is there, labor breathing, fever, persistent fever, and worsening stridor or biphasic stridor, you have to be come back. Okay. So we will discuss one stridor pop case. Okay, will be response through the chat. You are on call and are called the emergency department to review judge an 18-month-old boy. When you have arrived, he is sitting up in bed, breathing noisily with an occasional harsh cough. His mother tells you that he has been unwell for the last few days. With a cough, he has not eaten much and has not been keen to play. Judge is reluctant to interact with you, but when he does not talk to his mother, you notice his voice is hoarse. So what do you get? The child age is 18 months. So breathing noisily. Breathing noisily, what does it mean? Noisy breathing. Usually for the which it was not mentioned before. I didn't say. Actually, it is their language, no? How they are expressing problem. So breathing noisy usually means stridor. Okay. They said that having history of cough and not eating food appropriately, along with voice is hoarse. Okay, and vitals, they say respiratory rate, it's okay, temperature, heart rate, everything we find that for this child is appropriate. Saturation at 6% is also appropriate. He's using accessory muscles to breathe, and his heart transmitted sound on inspiration. So stridor is there along with transmitted, although it is said transmitted sound, and accessory muscles is using. Okay, no wheeze or crackles. Cardiovascular system examination normal. Capillary refilling time 2 seconds centrally. So what do you think? What is the most likely cause for this presentation? Although this question is likely to be task, but I hope it is not task. It is discussed in the FOB case chapter 5. FOB case book, you will get it. What is the most likely cause of this presentation? Please write in your chat box. Which one of the following is the main stay following? Is the main stay of management in this case, or along with which of the following investigation should be taken? Please answer these 3 questions by marking. Try, okay? Okay, only 2 answer. Okay. So you see that this is the likely cause is para-influenza virus C, because it is a case of acute laryngotracheobronchitis, upper respiratory infection followed by stridor. And following the mainstay in the management case, it should be oral steroid. And which of the following investigation should be undertaken? Investigation, blood sample, frontal neck, X-ray, MRI of the neck, no immediate investigation necessary. Throat stop, no immediate investigation is necessary. Child's neck is very narrow and short. If you, try to assess their throat or X-ray anything, it can be completely obstructed. So I hope it's now clear to you. Yes, thank you, Dr. Sadia. Right. Bodrun, I think you also can, if you try, you can do it. So everyone, if you concentration what I say, it will be very easy for you. That's all. So I think we discussed allergic rhinitis, but there is something more with the related to the stridor. So you know something is congenital stridor. Okay, so stridor in early life is congenital cause. There are different congenital cause can be related to the stridor. So you will get it in their very early part of life. Okay, neonatal life, infantile life. One of the very important cause is subglottic stenosis, which can cause, subglottic stenosis is one of the causes of stridor in the neonatal life, which is due to okay, then so subglottic stenosis when happen if the child is ventilated, ventilation history. So once upon a time it was said that if long time ventilation, then it can lead to subglottic stenosis. But nowadays they are saying that no, it's not like this. It's not related to the long time, ventilation. It's even 2 days ventilation can lead to subglottic stenosis. Okay, so one of the important causes is subglottic stenosis. And remember, it is biphasic. Biphasic. So both inspiration and expiration. If you try to hold too much concentration, you can get it. That is both inspiration and expiration. Another cause is hemangioma. So if laryngeal hemangioma, laryngeal wave, laryngeal, so all the things are like laryngeal usually. Hemangioma, laryngeal wave, tumor, it can lead to as well these kinds of this kinds of sound. And remember, hemangioma, if it is laryngeal hemangioma, you will get hemangioma in the body as well. So if you can remember your task in the dermatology, we said that hemangioma, more than 10 hemangioma in the body can have this laryngeal hemangioma as well. And if hemangioma in the body and it's a beard distribution, the hemangioma distribution in the beard area, think over this laryngeal hemangioma. Okay, so that is very important. Anything more is there? No. So anything, okay. So another thing is sleep disordered breathing. Okay, sleep disordered breathing. Here also we can get noisy sound. So the child complain of, in my practice, I mean, morning time, whenever we work in the outdoor practice, in that area, I got this child, I mean, one child who is seen by one of the pediatrician, one of our colleagues, long time, and for some reason it was not explored, and parents were saying that every night breathing was so much sound in the breathing, and sleep was disturbed, and child was wake up from the breathing, from the sleep. So if it is there, please be careful. It's called sleep disorder breathing, and it's should be investigated. Okay, so here are different cause why this happened. Okay, it's called sleep apnea. Sometimes they lost their oxygenation appropriately into the brain. Okay, during important things is this sleep, restlessness. So here behind due to, for example, adenotonsillar hypertrophy. Okay, so that child, whenever I heard that, immediately like, please go for extra nasopharynx lateral view, and within 30 minutes he was come back and great throat adenoid. So the child having failure to thrive and repeatedly took a lot of vitamins, but behind the cause is actually adenotonsillar hypertrophy. So please ask it. If you get that I mean, give time to the child parents so that they can express their problem, as well as sleep, how the sleep is. It's very important always how the sleep is. So any complaint, how the sleep is. Sleep is very important. Child sleep should be I mean, certain age they can be wake up and sleep, wake up, sleep. So it's a cycle. It can be happen, but after a certain age, they will be a smooth sleep, right? So if it is not there, we have to find out the sleep is disturbed, and that times what happened? Some sound is there, their mouth open, and they become bluish or something. So sleep obstructive sleep apnea, obstructive sleep apnea, OSA. It's not good. It's very bad because it's lack of oxygen. It's happened due to lack of oxygen. Okay, so behind the cause can be upper airway obstruction, and if it is there, it can be happen with some syndrome as well, like Duchenne muscular dystrophy, can be with cerebral palsy child, Down syndrome, Pierre-Robin sequence, achondroplasia. Some syndrome can be related, but it will be not a question for you. So if it is there, then think of investigation, and it is called polysomnography. Polysomnography is another name is sleep study. Okay, so sleep study. So, initially, whenever you have suspicion, you give this suggestion that oxygen saturation, detection of oxygen saturation, heart rate. So, it is like a whole night of oximetry. But then polysomnography is the treatment of choice, and this investigation chart is taken from the AKP master course book from the RCPCH. It's not in your book, because some questions related to this. So polysomnography can identify everything like ECG, that time whatever the ECG, so how was their sleep, and when they have sleep apnea that times, what about the saturation and other things. Okay. So these all are the things that we should know. Let us discuss followed by other things, but if there are any questions so far, you can ask me. If it is not, so we can start.